So first of all, sorry for these technical issues, and good afternoon, everyone. Thank you, faculty, for the invitation. I'm very happy to be there, but it's quite a difficult task now to talk after Jacques Moret, because I guess that now you know everything about web, and nevertheless, I will try to share with you an update on clinical use of web device and share with you some cases from our experience in Toulouse. Just to start, a few words about technical evolution, because it's important to know where the web comes from the beginning, and that can explain the different steps we should face to have now the use of the web and this experience. So the adventure started in 2010 with a dual layer. It was a large device in a large catheter, and then came the single layer with a barrel shape and a spherical shape. Then came the enhanced visibility device that was better seen, navigating through smaller catheter, 33 and 27 microcatheter. Then came the 21 system. And then the last one is, the last evolution is the 17 system, navigating through the 17 microcatheters, so with smaller devices and easier devices to deploy. So with the web, you can treat with the barrel shape aneurysms from 2 to 10 millimeters. As you can see, you have very small web from 3 millimeter by 2 to a larger one till 11 millimeter. With the spherical shape, you can treat aneurysm from 3 millimeter to 10. During this evolution, almost 10 years of web clinical use has been documented. It started with the WebCast study, then the French Observatory study, WebCast2, WebIT, Clarisse, and now Clever study. I will share with you results of these prospective multi-center studies. They are prospective, and they have independent event adjudication by a core lab. So it's quite interesting to share those conclusion. So we will talk about WebCast, WebCast2, WebIT, and Clarisse. All of these studies have the same endpoints regarding efficacy. Efficacy using this scale, the scale with adequate occlusion between complete opacification of the web proximal recess and neck remnant. That's defining the adequate occlusion, and the aneurysm remnant is considered as a bad result. Safety endpoint is the rate of adverse events related to the device or to the procedure. If we take a close look to the aneurysm characteristics, you can see that the device has been designed first for wide neck aneurysm and for bifurcations. So that explains that the inclusion criteria were corresponding to that kind of aneurysm. So the mean size neck was quite large, as you can see in those different studies, and mainly Mca aneurysm bifurcation has been included, but also basilar aneurysm, ICA, and ACOM aneurysm. If we pull all the results of the European studies, we will talk about the 3 GCP studies for a total of 169 aneurysm in 168 patients. It's about mainly unruptured aneurysm, and as you can see, mainly MCA aneurysm bifurcation with wide neck. Regarding safety, at 1 month, neurological events were SIH or ICH in 3 people, and probably 2 aneurysm procedure related. And the main complications came from thromboembolic events in 24 patients, but only in 5 patients, leading to permanent deficits. So morbid mortality at 1 month is 3% regarding morbidity and 0% in terms of mortality. At 1 year, we increased the mortality with 3.3%, but it's only 5 people, and 1 death is due to procedure because of retroperitoneal hematoma, which leads to consequences and complications. And the morbidity decreased a little bit, going to 1.3%. At 2 years, between 1 and 2 years, no more morbidity. Between 1 and 2 years, 2 more deaths, but not related to the procedure, but because of lung cancer and pneumonia. At 3 years, 1 more morbidity, but without any relation to the device or to the procedure, and no more deaths between the second and the 3rd year. Considering anatomical results, you have adequate occlusion, so mean neck remnants and complete occlusion in 79%, so very good anatomical results with more than 50% of complete occlusion. 2 years, it's slightly better, 89% of adequate occlusion, and at 3 years it's stable with 82% of adequate occlusion. So you see that anatomical results are quite stable by the time. In terms of retreatment, it's about 11%, around 11% of retreatment at 3 years. It's quite comparable to studies such as MAPS and branches with the subpopulation of wide neck aneurysm, in which MAPS, for example, faced to around 13% of retreatment in case of treatment with coils, and 14% of retreatment in case of treatment with stents and coils. So stable at 3 years with quite comparable rates of retreatment with the literature. If you want to have more information, you can read this paper written by Laurent Pierrot in AJNR. Now, let's move to WebIT. Those are the results presented in ABC WIN. As you can see here, the results of WebIT. So first, WebIT is about 150% in a USA cohort plus a Turkish cohort. The morbidity is quite equal to the GPC study without any mortality. And adequate occlusion is very high, with 84% of adequate occlusion at 1 year. So very comparable results from the GCP studies. So those studies were mainly for unruptured aneurysm, even if they got a small amount of ruptured aneurysm. But what about ruptured aneurysm? We have a few retrospective studies, and as you can see, a few numbers of patients, but mostly without any re-rupture rate during the control, except in this series of 2 patients facing a rebleeding. So the goal to study ruptured aneurysm was the goal of Clarisse, and Clarisse has included 60 patients and has less than 3. And the maximum width aneurysm to be treated was 10 millimeters because of the size of the device. And as you can see, the population of the aneurysm were mainly AECOM aneurysm, then MCA bifurcation aneurysm, then basilar tip aneurysm, and other in a few cases. The primary endpoint was the rate of rebleeding from the post-procedure up to 1 month. The screening was during the procedure, doing a flat panel before starting the treatment and systematically after the procedure to see if we have rebleeding, and CT was performed in any worsening of the clinical status. And at 1 month, 0% of rebleeding were expected. Regarding mortality, low mortality, 1.7% at 1 month, but not device or procedure related, and 15% of morbidity, once again, not related to the device or the procedure. At 1 year, Clarity showed interesting results, also the same, quite equal to the GCP, with 87% of adequate occlusion and a retreatment rate at 11%, around 11%. So the conclusion of these studies will be web is safe, conducting to a low morbidity and a low mortality rate. It's suitable for unruptured aneurysm, but also for ruptured aneurysm, because we saw that there is a low rate, no rebleeding in Claris study. It leads to good anatomical results and stable within the time till now, with at least 1 year of control and 3 years for the GCP. And the rate of retreatment is comparable to other series of wide neck aneurysm treatments. A study ongoing is CLEVER. CLEVER is about 160 subjects, mainly unruptured aneurysm, to assess the clinical utility of the 17 system to treat so bifurcation, also intracranial aneurysm. The enrollment is completed. We are waiting the first results, and they are expecting soon. So now our team experienced about a few cases. We started to treat aneurysm with web from the beginning, and I must confess that there is a large learning curve. The key point, or the main key point, is about the sizing and also which kind of aneurysm we should treat. The first case we treated was this case with the unruptured right Mca aneurysm in a 61-year-old patient. As you can see, this is a complex shape aneurysm with a very large neck aneurysm. Difficult to understand on a 2D, but we put a device, it was a 8x4 dual layer, and to avoid moving, to avoid displacement, we put a balloon in the upper branch because we couldn't control very nicely the branch on the projection. Everything went well. This is the supposed position of the web. As you can see, at this time the dual layer was very poor visibility, but nevertheless we faced no bulging into the MCA bifurcation. This is day 1 MRI control. This is 6 months control, and this is 18 months after the treatment. As you can see, there is a remnant that increased by the time. The second case was this Mca aneurysm in a 50-year-old female with this large neck. We put a 9x5 dual layer, and as you can see on this vaso-CT, it seems to be in a good position without any bulging, without any kind of remnant. This is day 1 MRI. But this is 3 months follow-up, and this is 18 months follow-up. And as you can see, the remnant is not very stable. So our first 15 cases were not very, I will say, adequate. And our results pushed us to publish this article about 15 cases. And we saw a worsening of the the occlusion with a kind of recurrence and compression of the web cage. We were asking ourselves why we observed that remnant and increase of remnant, and perhaps it was because of the beginning of experience, because we only decide to treat very difficult aneurysm with complex shape and very large neck. Perhaps we are very shy to avoid thromboembolic complication, and were all undersized. So that's why learning curve is very important. It was perhaps because of the dual layer, and at this time web was poorly visible and it was difficult to understand exactly what we were doing. About the shape modification, we faced a shape modification, but what does this mean? Does this mean a retraction because of the clot, compaction because of a hammer effect? And does this mean recurrence? We didn't know. A few words about that. This is a Mca Aneurysm. Incidental. We put this web, it seems to be nicely opposed without any remnant at this time. This was post-procedure, and this was at 6 months with this donut shape. And on the 2D DSA, we saw that neck remnant. It's still adequate occlusion, but it has changed from the time of the procedure. The second case, Mca Aneurysm, also incidental, nicely deployed without any remnant at the time of the treatment. At 6 months, we no modification in the shape of the aneurysm, but at 18 months, we faced a compaction. But when you look at the 2D, it was at 6 months, the device was still filled by contrast, but at 18 months, the aneurysm is totally cured. So compaction doesn't mean, of course, a recurrence in all of the cases. And that's the aim of this paper I found. They explored the anatomical results regarding the shape modification. And finally, anatomical results were not worse in case of web modification. I found also this paper from the Montpellier team, and it seems that they face more shape modification in case of irregular shape aneurysm with a wide ostium and a higher aneurysm dome size. So it does exist, but we don't still know what means compaction or modification shape with recurrence or canalization. But after this first experience, we changed our strategy, and it seems that we have much more better anatomical results since we have decided to oversize the device and to lead to a kind of activation of the device, to model the device. As Jacques Moret told you, we applied the rules of +1 millimeter in diameter, of mean diameter, and -1 millimeter in height. And I will share with you those cases. This is an incidental pericallosal aneurysm, a square shape, large neck aneurysm, difficult to put a balloon. You can put, of course, a flow diverter, but we decided to put a web. It was a 6 by 4 millimeter web, so largely oversized regarding the width of the aneurysm. You see it's a straightforward procedure with one microcatheter. You deploy one device with a nice sealing of the neck, and this is the result that is stable over the months. Another case with these Mca Aneurysm, encheminé shape, with this virtual imaging of the web inside the aneurysm, a 6 by 5 millimeter. So imagine we have largely oversized the web. So what do we expect? In fact, this is to show you that the web will nicely change its shape, and you see the highly conformability of the device. This is the immediate results after the procedure, and this is the 2 years follow-up showing a stable occlusion of the aneurysm. In this case, the web was very helpful. It was a WFNS4 SIH, and each time we decleave the patient, the intracranial pressure was increased. So we need to treat this patient very rapidly, and it's not easy when you have this large neck. You can imagine to put 1 balloon, 2 balloons, put coils, but using the web is a very rapid technique and a very straightforward, and it lasts at least 15 minutes, and it was easy to deploy this 11 by 9.6 web into the aneurysm, obtaining these immediate stagnation within the mesh of the web with protection of the rebleeding. Another case with this patient, WFNS3, Fisher 4, this very small aneurysm with large neck, ACOM aneurysm. What to use? Difficult to use a stent at this time because of ruptured aneurysm. It's quite easy to imagine to put a web, but it was very helpful in this case to use a balloon. So don't hesitate to use a balloon to modify the anatomy of the artery or to modify the position of the tip of the microcatheter. And we were able to deploy this 4 by 3 millimeter web and to seal the neck and obtain these quite interesting results. My conclusion will be web is very easy to use because it's a straightforward procedure. Don't hesitate to play with it, to use balloon and to deploy it, resheet it, and try to replace it in different way. It's very easy to use. Of course, you have a learning curve, and the sizing is the main key. And in our experience, finally, with the difficult starting with the web, we after oversizing, we see that it leads to better results in terms of occlusion. Use a Vaso-CT because usually you have a very difficult shape aneurysm, and it's better to understand the branches of the bifurcation. Web 17, as Jacques Moret showed you, widen the indications because the initial use was only wide neck bifurcation aneurysm, but now you can imagine to use it in berry aneurysm in other locations. But there is still a need to understand shapes modification and the role in healing process or in recanalization. Thank you for your attention.